Welcome to This Explainer. Today we're unpacking a critical medical mystery. How do you tell if lower back pain is just a frustrating nuisance or a life-altering emergency? We all know someone with a bad back. Maybe you're dealing with one right now. But the line between resting on a heating pad and rushing into an operating room, it's incredibly thin. So we're going to decode the exact differences between a super common L5 nerve root compression and a truly terrifying condition known as Cauda Equina Syndrome.
Okay, here's our roadmap. We'll cover the back pain spectrum, zoom in on L5 compressions, escalate to Cauda Equina Syndrome, learn to translate an MRI report, and finally, walk through the exact patient assessment protocols doctors use in the ER.
The back pain spectrum.
Imagine this. A 32-year-old patient starts out with a simple bulging disc, right? But suddenly she develops pain down both legs and this really strange ache right at her tailbone. This sets the stakes for us immediately. On one side of the spectrum, we've got an L5 nerve root compression. It's localized, it hits a single nerve, and it's a non-emergency. You usually just manage it with physical therapy. But on the complete opposite side, Cauda Equina Syndrome, or CES. This is a multi-nerve bundle compression, and it is an absolute surgical emergency. One means you schedule a PT appointment for next week. The other means you literally have 24 to 48 hours to get into an operating room before the damage is permanent.
Section 2. L5 nerve compression. Let's start with the familiar, right? Most folks know this localized issue as sciatica, happening right down at the L4, L5, or L5-S1 vertebrae. When the specific exit door, the foramen, for that L5 nerve gets pinched by a herniated disc, you get these highly targeted symptoms. Usually it shoots down just one leg. You get that classic sharp radiating pain from the glutes all the way to the foot. You might even have dorsiflexion weakness. That basically just means you have trouble lifting your foot up. Some people call it foot drop. You'll probably feel some numbness right on top of your foot or the big toes too. But here's the kicker. Your primary knee and ankle reflexes, they usually stay completely normal. So yeah, it hurts like crazy, but it's totally confined to one specific pathway.
Section 3. Cauda Equina Syndrome.
Now here's a wild anatomical fact. Your actual spinal cord ends around the L1 vertebra. Below that, it sprays out into this bundle of free-floating nerve roots called the cauda equina, literally horse's tail in Latin. CES happens when this entire bundle gets crushed all at once. And that brings a massive, massive jump in severity. We're going from a single squeezed nerve to multiple nerves. We're upgrading from taking some ibuprofen to an immediate surgical emergency. We are literally comparing the risk of chronic, localized pain against the devastating risks of permanent paralysis, plus the permanent loss of bladder, bowel, and sexual function. It is, quite frankly, a catastrophic system failure. Which, of course, begs the terrifying question: when exactly does CES become permanent? To understand the absolute urgency here, we have to look at how this syndrome progresses clinically. It's not just an on-off switch, it is a rapidly closing window. Doctors basically divide it into two main stages. First, you have CEIS, or incomplete. Think of this as the body's early warning system. A patient might have a neurogenic bladder, meaning they really have to strain to pee, but they don't have full urinary retention just yet. They might also notice some partial numbness in the groin area. Listen, this right here is the critical window for a full recovery, because if you miss it, you drop into CERIS, or retention. At this point, the nerves are squeezed so hard they just stop sending signals. The bladder fills up completely painlessly, and the patient literally cannot pee, leading to overflow incontinence. Dense saddle anesthesia sets in, and the prognosis for getting those functions back drops off a cliff. And the scariest part? Going from incomplete to retention can happen in a matter of hours.
Now, I gotta throw a slight anatomical curveball your way. Pure CSR happens lower down, right? And because it hits peripheral nerves, it causes flaccid, limp muscles. But what if the compression is just a tiny bit higher up, around T12 to L1? Well, that actually hits the very tip of the spinal cord itself, causing something called conus medullaris syndrome. And this creates a really confusing mixed picture of symptoms. Instead of just limp muscles, the patient might actually have hyperactive reflexes, or a positive Babinski sign, which is when your toes point up instead of curling down when the bottom of your foot gets scratched. It's an absolutely crucial distinction for a neurologist to catch.
Section 4. Translating the MRI.
If you've ever tried to read an MRI report, you know it basically looks like a foreign language. But honestly, once you know what to look for, it's really just describing plumbing and space. One of the most critical numbers you'll see is the AP canal diameter. That's the anterior-posterior measurement of the spinal canal. Think of your spine as a pipe. This measurement tells the doctor exactly how much free-floating space those delicate nerve roots have from the front of the pipe to the back. In a normal, healthy spine, you want well over 15 millimeters of breathing room. But if that report says the AP diameter is less than 10 millimeters, you are in the danger zone. You have what's called absolute stenosis. The pipe is critically narrowed. And this is so vital because, think about it. If someone with a nice, roomy 16 millimeter canal gets a 10 millimeter disc herniation, they've still got 6 millimeters of spare room. But if you start out with only 10 millimeters of space, that exact same herniation is going to critically choke off those nerves and trigger Cauda Equina Syndrome. So it's all about knowing the key words radiologists use. For a standard localized L5 issue, they'll use terms like lateral recess, foraminal, or abutting. That just implies a side issue. One single nerve is getting bumped. But CES, that triggers terrifying volume-based language. You'll see phrases like massive central herniation or thecal sac effacement. Effacement literally means the fluid-filled sac holding that entire bundle of nerves has been completely squashed flat.
Section 5. Patient Assessment Protocols. All right, let's put on our medical detective hats. Let's go back to that 32-year-old patient who developed a non-tender ache in her tailbone. Doctors have to figure this out fast. Is it just Coccydynia or is it CES? Coccydynia just means you bruised or inflamed the actual tailbone bone, like maybe you slipped on the ice. But if a massive central disc herniation is crushing those sacral nerves way higher up in the spine, it can actually send a referred ghost pain straight down in the tailbone. We call that mimic pseudococcydynia.
And the physical test for this is fascinatingly simple. Doctors call it the press test. If a patient has true coccydynia, the bone itself is bruised, right? So if a doctor presses directly on the tip of the tailbone, boom, it causes sharp, exquisite pain. But with pseudococcydynia, caused by a spinal emergency, pressing on the tailbone does absolutely nothing. The bone is perfectly healthy. The pain is a false signal coming from a really dangerous nerve squeeze happening upstream. So because our patient failed the press test, meaning her tailbone wasn't tender to the touch, her doctors instantly know her pain is coming from her spine. And that is a massive red flag for early Cauda Equina Syndrome. So the clinician has to rapidly fire off these subjective screening questions. Does toilet paper feel numb or different when you wipe? Do you have to strain to start peeing? Does the seat feel numb or kind of floaty on one side? They are rapidly checking for saddle anesthesia and early autonomic failure.
If any of those subjective answers are even remotely concerning, doctors can't just guess. They have to map out the objective saddle sensation. The patient lies on their left side, and the doctor uses a neurotip to test 3 specific concentric rings of skin that are supplied by the lowest sacral nerves. Step 1 is the outer ring, the S3 dermatome out at the buttocks. Step 2 is the inner ring, the S4 dermatome right at the perineal skin. And step 3 is the bullseye, the S5 dermatome right at the anal opening. Any dullness or lack of sensation here, it's an absolute emergency.
As a final, super vital objective measure, doctors check a physical reflex known as the anal wink. Basically, by gently scratching the skin near the anus, the external sphincter should visibly contract. If there's no contraction, that is a hard clinical sign. It confirms exactly how damaged those lowest sacral nerves truly are, proving that the reflex arc has been entirely broken by that compression higher up. And that brings us to our final thought. The line between a conservative physical therapy plan and an emergency spinal surgery is razor thin. So what if a minor backache today is actually the 24-hour warning bell for permanent paralysis? Knowing these precise red flags, from a sudden drop in urinary function to a weird numbness when you sit down, might just save your mobility or the mobility of someone you love. Listen to your body and never ignore the warning bells.